registered on the call today with a lot of different backgrounds, and hopefully I'll be pitching it so that everybody will be able to sort of take something away from today's webinar. So today's webinar is all about the development and the clinical trial involving a behavioural intervention that was developed both with and for users of urgent dental care in order to support their transition into planned care appointments. So in particular this afternoon, we'll be talking through the findings of a major randomised controlled trial that took place in NHS dental practices in a dental hospital in the northwest of England. And we've got Dan Howden here, who's going to talk through the health economic results a little bit later on. But we've got people here that are registered for the webinar today from a variety of backgrounds, people working in policy roles or commissioning roles, both locally and nationally, people working in dental practices, both in the NHS and in the private sector. And we've had quite a few people register for the webinar from different countries, from Australia, America, Peru, even Vietnam, and several European countries such as Latvia, etc. And so this is because this type of work is fairly unique in its own, because whilst this is an issue throughout the world, there has been almost no intervention work in this space. And there's definitely been no major trial in this space either. So there's lots of learning, both from a policy and commissioning point of view, from what could happen in terms of delivering best care to dental patients and the population, and also the learning that we can take from this in terms of research. And it's pertinent also internationally. So thank you for joining us. And we're very happy to pick up different conversations about the work after today's call. So do get in touch if you're interested. Next slide, please, Victoria. So before I really get going telling you a bit about Return, I want to acknowledge all the partners that have been involved in this work. I'm the chief investigator for the grant, but there's been a number of co-applicants, universities and different people who've been involved in different aspects. And I want to also acknowledge the contribution and the advice from our steering committee, who met periodically through the programme of research. Now, the work itself, as I've already mentioned, is the field work was done in dental hospital and a range of NHS practices, and these are a few of the logos here. But also my team of researchers here in Liverpool who have been involved in the day-to-day delivery of all the field work, the public engagement work, developing the intervention and delivering the trial and follow-up, as well as the research. So these are very dear colleagues of mine, and I'd like to acknowledge their contribution today. So this work was funded by NIHR, which is the major funding body for health research in the UK, and we were awarded £2.4 million right back in 2018. Now, this is the only, to my knowledge, the only programme grant that there is awarded to dentistry. And what a programme grant does is it takes packages of research and that's viewed that if the different research projects taken together over a period of time will significantly move that area of research forward and make an impact on the delivery of healthcare, but also what we know in terms of research. So I'm delighted to get to the end of this programme grant now and to be able to share our learning. Next slide, please. So when you do a grant application like this, you have to articulate the issue. The issue, and this is something worldwide, is that people often get stuck in a cycle of urgent care use. So they don't go into routine or planned care, they just turn up when they've got a problem. And there's an issue with this, both for the individual person and also for the health service. because we know that this can increase health inequalities. It results in poorer health outcomes, and it also wastes NHS and health services resources. Next slide, please. This is some data that stands behind what I've just said. These impact individuals that are often least able to take the additional cost associated with using urgent care repeatedly. They often are also the people with the worst oral health and health in general. And we know that if people just purely rely on urgent care, that they're much more likely to lose their teeth. We've got several longitudinal population studies from a variety of countries showing that if people are just purely problem-based attenders, they're 2 to 3 times more likely to lose their teeth. If people just turn up with an acute problem at a dental practice, we also know that back in 2015, from a study there in dental practice, as many as 57% of those attendees of urgent care in dental practice were receiving a prescription of antibiotics, which is not ideal for the individual, and it's certainly not ideal in terms of population health outcomes and antibiotic and antimicrobial resistance. Now, problem-based visiting means delayed dental visiting, and it means increased dental anxiety. And this creates a loop of dental avoidance, because we know the longer that individuals leave visiting a dentist, they get more anxious. And when they then turn up for with a dental problem, their intervention is going to be perhaps more challenging for them, and this increases their anxiety as well. And what we see is a cycle of dental avoidance. So the cycle of urgent care becomes repeated. For that individual, they also face individual higher lifetime dental costs. The cost of their dental care as an individual is going to be more. And if you look at the evidence here in this outlined green box, this is taken from a Medicaid study looking for people participating in the Medicare system in the US enrolled continuously for 5 years. And those adults that had no preventive care in that time ended up with 43% higher dental costs than those people that received preventive care. And not only that, they had a variety of different other impacts, such as being 5 to 6 times more likely to have a dentally related opioid prescription. But it's not just this higher lifetime dental costs. It impacts individuals' disposable income every time they have an urgent care visit. There's a study done in 2023 that shows that each urgent care visit in the UK, the individual faces out-of-pocket costs on average of £86. And that covers any fees involved, but also the travel, cost of childcare, medication and time off work. That's £20 per visit just on transport and medication. Next slide, please. And so what we see is a vicious cycle, or a vicious circle of repeated urgent care use, that where people start off in a low socioeconomic category, they start off with a higher chance of having more disease, and they end up with fewer teeth and higher impacts, more anxiety, more likely to delay care, using more of their disposable income, having had more time off work, and this reinforces health inequalities and social inequalities itself. And this isn't just a one-off pattern, it happens repeatedly, as you can see in this green box here in a study in 2015 in a northeast dental hospital setting, where a third of those patients attending with a dental emergency had previously attended the dental hospital for an appointment, and 13% had even consulted for the same problem. So this has real impacts for individual people that can at least able to be resilient against that stress. But it's not great for the health service either, because there are additional costs of providing urgent care over routine care. For example, even the infrastructure costs of providing a triage service and a telephone helpline for individuals seeking urgent care. And back in 2015, this was costed at between £5 and £7 per helpline call. And that would be now inflated 10 years later. Now, if people don't manage to or don't end up accessing dental services, they may have a knock-on effect for other health services too. And we know that this can often be an issue. Each additional visit to A&E with a minor problem costs the NHS in England £114. That's data from the King's Fund in 2025. But they're also the service is less likely to be preventively orientated. We treat things as a later stage. We do more intervention. We spend more on lab fees. People end up with worse health. And so again, we have a vicious cycle in terms of health resources. Next slide, please. So this is where return is positioned. It's an attempt to develop an intervention to disrupt this vicious cycle, both for individuals, particularly for those from disadvantaged backgrounds, but also to produce better value for money for health services in general. Next slide, please. I'm just going to hand over to Victoria now, who's going to talk you through the return intervention.
Thanks, Rebecca. So as mentioned earlier, my name is Dr. Victoria Lowers, and I have worked on the Return project for the past 8 years as Programme Manager. A key part of my role was to design and deliver the training that enabled dental teams to use the Return intervention with their patients. Having overseen both the development of the intervention and its day-to-day delivery, I can walk you through its key components and illustrate how it worked in practice, and that's going to be the focus of my segment in this webinar. So the Return intervention was designed for the urgent dental care setting, making use of something called a teachable moment, where patients are often more receptive to changing their behaviours to avoid future urgent problems. The intervention consists of 2 core components. First, the physical return materials, which consist of a booklet pack plus videos addressing common barriers people experience to dental attendance. This pack is split into materials to view with a dental team member in the dental practice and materials to view at home, and the full physical booklet pack is taken home by patients. Second, the pack is supported by a facilitated conversation delivered by dental team members. In our case, this was dental nurses. Dental nurses receive training on both the practical steps of delivering the intervention and on how to hold motivational interviewing-based conversations, which is an evidence-based behaviour change technique that I'll talk about a bit later. Training combined a face-to-face didactic session with supervised practice with real patients. For many dental nurses, these were new skills, so building confidence through hands-on practice was vital. On average, delivery took 15.8 minutes to complete, and there were 5 main steps to deliver the intervention, which I'm going to go through now next in turn. So the first step to delivering Return is to identify and explore the patient's barriers to dental visiting. This might include discussing their past experiences at the dentist, how important they feel routine dental visiting is, or issues such as shame, embarrassment, or anxiety. The discussions are guided by motivational interviewing principles. This is a behaviour change technique focused on how you are with patients, not just what you say to them. It's rooted in 4 key elements, which are partnership, acceptance, compassion, and drawing on what matters to the patient most. In dentistry, conversations can often centre on educating or advising, but motivational interviewing requires a shift from directing to guiding, creating space for the patient's voice and helping them explore their own reasons for change. In return, motivational interviewing techniques are used to support patients to move towards attending the dentist before they're back in pain. So the goal of this first intervention step is to help patients identify their own barriers, encourage reflection, and build rapport. After the initial discussion, patients are then guided to select the barrier they would like to focus on for the rest of the session, and that's one of the 6 that you can see on this slide here, which are common barriers to avoiding dental attendance. In step 2, patients are shown a brief video that matches their barrier they selected as the focus of their session. The videos feature real patients sharing their own experiences and how they overcame their barrier. This step is underpinned by social identity theory, which says that patients are more motivated to change when they can see themselves in stories or materials that are being told to them. So it's a bit like, that person is like me, if they can do it, so can I. I'm going to show you one of the videos here that we have for the barrier of anxiety. And it features David, and this is someone we met during the development of the intervention at a local community centre. David spoke to us openly about his past anxieties around dental visiting, and he kindly agreed to share his story so it could be included in the intervention. It's a couple of minutes long, and I'm going to play that for you now.
My name's David. This video was all about anxiety of going to the dentist, and I'm going to sort of give you a little insight into, my anxiety and how I sort of overcome that and started going to the dentist again. I think a lot of the time in my teenage years, I just wasn't brushing them and just going out and having a manky mouth, if you like. And again, it just stayed with me until when I became into, an adult. When I was in the military, there was a little bit of a scare, and the little scare was there was an abscess on me in my mouth. And so that sort of, scared me again about going. At one point, I said, I'd rather go back to Afghanistan than go to the dentist. And, at the time, well, now it's like, no, I'd rather just go to the dentist and pay the 50 quid or whatever it is than, be in a war zone. But at the time, when the anxiety's high, it's like, yeah, I would have rather been in a war zone than gone to the dentist. So there was one time when I was sitting outside the dentist, I'd made the appointment over the phone, everything like that, and I sort of, bit the bullet and went, right, I need to go. And I was sitting outside the dentist in my car, and I was like, right, I'm going to go in now. And then I just got on my phone and just started playing on my phone. And it was like you were I was unconsciously trying to stop myself from going. And it just got to the point where I just drove away and just didn't go. And I rang the dentist on the way there to work and just said, listen, I couldn't come in, can I rebook the appointment? How did it get myself to the point when I managed to go back? I'll speak to anyone, me. So I did tell them about my anxieties about going in and all that, and they were just dead nice. So that was just in the waiting room. And then when I went in, dentist was brilliant, dental nurse was brilliant, and obviously I went for a checkup. They told me what I needed, and then I had to go back. That just lowered the anxiety straight away. As soon as I sat in the chair, spoke to the dentist, I knew that, it was sound going back. I think talking to people, because at the time as well, I was like, I need to go back to the dentist. What's the best dentist? And, asking around my family, asking around friends on who was the best one to go to. I rang up about five or six different dentists, and I had appointments with them, yet they won't let me go now because I missed the appointment. I didn't go. And then there was just this one where I'd spoke to a friend and he were like, no, go to this one. This is perfect. I've been going for years. So I'll go now if you want. Yeah, I will. And I feel great about going now and knowing that I can go in and I can, ring up, ask questions.
So then after watching the video, the intervention deliverer invites the patient to reflect on what they've seen in that video and how it might reflect their own situation.
My name's
So after the video, patients are given a guided walkthrough of a short intervention barrier booklet. Each booklet is packed with relatable patient stories, simple facts, and practical tips designed to help people take small, achievable steps towards overcoming their challenges with attending dental appointments. Behind the scenes, the messages draw on a range of evidence-based behaviour change techniques to build motivation, strengthen self-belief, and offer clear supportive strategies. Patients can explore the booklet in their own time at home, so the dental team's role is to offer a quick, focused overview during the visit. Dental team members are encouraged to add their own supportive comments, provided they stay within motivational interviewing principles. So this means keeping the conversation patient-centred, non-judgmental and empowering. All the materials are written to a reading age of 8 years to ensure they're accessible, inclusive and genuinely useful for as many people as possible. In step 4 of 5, dental team members guide patients to create a personalised goal and action plan. And this again is an evidence-based technique that can help people to change their behaviours. These plans follow SMART principles, so they needed to be specific, measurable, actionable, realistic and time sensitive. Using motivational principles again, the dental team member's role is to support the patient to generate their own goal and plan in their own words and grounded in their own circumstances. This increases the likelihood that patients will follow through. The plans were written directly into the booklets and patients took them home with them. So the last intervention step focuses on encouragement. Here, dental team members reinforce the value of continuing to use the materials at home, highlighting the Next Appointment Toolkit. And this is a booklet that's contained within their booklet pack designed to support patients between visits. It includes practical information on arranging dental appointments and supportive resources such as breathing exercises for anxious patients. The aim of this step is to help patients feel more prepared, confident and supported as they move towards the next stage of care, and they are required to use positive forward-looking statements, encouragement and self-efficacy support. We're now in the process of translating this intervention into an online toolkit, including a free training suite to support dental teams in delivering it to their patients. We would welcome any input with this, and if anybody would like to be involved during this phase of the development or to be involved in any piloting we do, please do pop a message in the chat, as we'd be very interested to hear from you. That's it from me. I'm now going to hand you back to Rebecca.
Hello, thanks very much, Victoria. So we've developed this intervention. Before I go on to talk about the trial itself, I think it might be useful to just mention how it may fit within the current NHS dental contracting landscape. Because at the moment in England, we hear a lot about urgent dental care and the services and the system innovations to support that. But I'd just like to sort of just touch on that very briefly before we go into the trial results itself. Next slide, please. Can we move on, Victoria? So as I've said, at the start of this current government, there was a manifesto pledge for an additional 700,000 extra urgent care appointments to be delivered. And so subsequently, we've seen an increased focus on the increased capacity in NHS services to deliver urgent care. But alongside that, we've also mindful of the fact that it's not a great use of NHS resources to deliver something that promotes a revolving door of urgent care. There have been several innovations at different parts of the country where people have developed follow-on models for commissioning, completing a course of treatment or stabilising people's oral health after that one-off urgent care appointment. So it's looking basically at what is coming up the track in terms of it may be the next urgent care appointment, urgent care need for that individual person, and to stabilise their oral health so that they're not going to be before long heading back into the urgent care system. And obviously from the individual's point of view, who hasn't used urgent care, hasn't used planned care for quite some time, this can be quite a big hurdle for them to overcome, to come back after an urgent care appointment. Next slide, please. Now, there's an evaluation here done from NHS Sussex of their urgent care and stabilisation commissioning programme. where they found that only 40% of patients who were offered stabilisation appointments took up that possibility after the urgent care slot. And even for those that booked the stabilisation appointment, there was 14% of failed to attend appointments. And so even against the backdrop of system, health service and system innovations to support follow-on stabilisation appointments, we still need to pay attention to types of patient behaviours and reasons why patients may be still stuck in an urgent care loop, even if there were follow-on appointments that were readily accessible to them. Not only is the stabilisation model growing in England, but there is also some attention being paid to increasing the remuneration so that for people who haven't attended the dentist for routine care for quite some time. As people working in England will be aware, there's been a recent consultation on possibilities of payment reforms with proposed longitudinal and higher payments for patients experiencing unmanaged dental caries and periodontal disease. And these are exactly the type of patients from low income groups that we're thinking about in terms of the return intervention. So this return intervention is focused on patient behaviour, but it's as well as and accompanies system innovations to support the use of this user group into planned dental care. Next slide, please. So let me talk you through the research programme itself and the timelines and what was involved. Next slide, please. As I've said, it started right back in 2018 and we were funded at different stages and different milestones from NIHR. We worked with community groups, as many as 22 local community groups, and some of them for quite some time, who were involved with people of that socio-demographic who were high users of urgent care in the area. And we purposefully set about engaging with a whole set of different groups. Some of them were men, some of them were young men, some of them were older people, right across the age and the different type of backgrounds. And we also had quite concerted co-working with a community advisory group who were not all at any means were regular users of dental services, and they helped write the script. Many of them featured in the videos that were part of the intervention, and so that this is basically formed the intervention itself so that it could speak to the relevant social identity. When the intervention was developed, we went into a feasibility stage, answering the question for NIHR, could this trial be delivered? Could we recruit people into a randomised controlled trial that was delivered opportunistically to individuals just purely turning up without expecting to be enrolled in a randomised controlled trial with all the paperwork that means and the follow-up that comes alongside it? And that was passed successfully. This you'll see here circled in red, those years that will always stay with all of us in terms of our memories, because these are the COVID years. And you'll see as we went through the feasibility study and also then into the randomised controlled trial itself, we were just coming out of the COVID recovery period, where we start to see that the impact on routine dental service provision. So this needs to be borne in mind when we interpret the results of return, and I'll be mentioning this in a minute. But we went ahead and we were funded and supported by NIHR to start recruitment in August 2021, and we successfully met our milestones just 6 weeks past the 12 months milestone to recruit 1,180 people. And it's a signifier of how much use of urgent care there is, that we recruited all of these people within Cheshire and Merseyside, which is the area that surrounds Liverpool in northwest England. And these individuals were followed up for 6, 12 and 18 months later. Next slide, please. This is what actually happened to the provision of dental services in Cheshire and Merseyside. Before COVID hit, 122 practices in this area were taking on new NHS patients who hadn't had routine care there before. But at the start of the recruitment period, this dramatically fell in the post-COVID recovery period. And that only really, that burbled along the bottom to about only 15 practices in that area accepting new patients, and actually dropped quite badly during the end of our follow-up period. And so for these people participating in return and trying to be supported into return care in this area, it was actually extremely difficult to find planned care appointments for them. Next slide, please. I'll talk you now through the headline findings. Next slide, please. This is what you see in any randomised controlled trial. As I've said, we did a sample size calculation that was approved at the start, that we had to recruit 1,180 patients. They were all adults aged over 18. And these were people who were confirmed as not having attended a dentist for 2 years for non-urgent care. And we had to confine this to people not that were able to speak English fluently, because we didn't have the capacity to translate materials or to get interpreters. That would be a further development. So we successfully randomised these patients into half of them receiving the intervention and half of them receiving the control. Then we were followed up, and you'll see here the numbers followed up in intervention and control groups. The control groups were people who just received standard care. They didn't receive anything other than the usual care in the NHS and dental hospital settings that they were recruited in. Next slide, please. Now, this is the social demographic of those people recruited. You'll see here that the key thing that you want to look at in a clinical trial is whether or not the intervention and control group are roughly balanced by social demographics. So you'll see here the green and the pink are roughly patterned in terms of they reflect the same proportions of people in terms of socioeconomic disadvantage. But what you can really see quite clearly is when divided into the index of multiple deprivation decile, over half of these urgent care users were from lived in the most deprived postcodes of England in terms of the lowest 10%. Quite a few of them were unemployed, and a significant number had no formal qualifications education-wise. And we didn't purposefully set out to oversample people from a lower socioeconomic demographic, but this is reflective of quite a few people that use urgent care repeatedly. Next slide, please. And so we followed these people up, and we followed them up in 2 ways. They received questionnaires, and we needed to get as many responses as possible. So we did it in lots of different ways. Firstly, we had attempts at telephone contact and to fill in the questionnaire over the phone. If there was no contact, then we emailed, and we also sent them out as post. You see, in terms of getting our response rate up. Inevitably, particularly for the social demographic, you're always going to get a bit of response bias and a bit of dropout. And so we also, alongside this, looked at outcome data from the payment data for NHS dental practitioners that is held centrally by the Business Services Authority. The downside of that is that we have to match the individuals who were recruited in these different settings with these IDs centrally held by what's called the BSA, and also it only reflects NHS services as well. So both of our outcomes have positives and negatives about them, which is why we've got 2 types of ways of following people up. Next slide, please. So basically, in this clinical trial, and it's not completely unusual, but in the clinical trial, you do the sample size calculation on what's called primary outcomes to judge whether or not your intervention was effective for that group. And so we set out, before we started the trial, and it's all written out and published in a trial protocol, that our primary outcome to see whether or not it would work would be on the basis of two co-primary outcomes because of the upsides and downsides of each. We'd use that routine data set, routine care from the BSA. That would be indications that they'd taken up a planned care appointment. And then secondly, we'd use their responses from the questionnaire and to see what the impact of oral health was on their lives. And that was using what's called the OHIP 14 scale of 14 questions. And that's the second self-reported co-primary outcome. But they answered a lot of other questionnaires as well. And we also set out a number of what's called secondary outcomes. There are as many as 14. And what secondary outcomes do is they help to explain what's going on in the trial and whether or not it's effective or not. So we collected data, for example, on dental anxiety. Even though our primary outcomes were positioned for outcomes at 12 months, we looked at what was happening at 6, 12 and 18 months. We looked at self-reported dental attendance on the questionnaire, both in private and NHS services, because it's a mixed economy in the UK. And this is particularly important given the COVID backdrop that I've explained earlier. We looked at the treatment received by both in terms of self-reports and the BSA data. And also in the self-report, there was a secondary outcome about attempts to make an NHS appointment. Next slide, please. So this is the key findings in terms of the clinical trial. The first primary outcome. Did the BSA data show that within 12 months of delivery of the intervention, was there a greater chance that people receiving it had taken up and attended a planned care appointment? Now we can see that there is a slightly increased proportion of people in the intervention group. And when you look at an odds ratio, that means that there's 20% greater odds of attending an NHS planned care appointment based on this data. If you look at it in statistical terms and the p-value and the confidence interval, because that confidence interval crosses 1, this means that that finding could have happened by chance. Now you'll hear me say that a number of times in the next few slides. And what we'll find as I go through all of the outcomes is that they'll all say the same thing, basically. But we need to also bear in mind whether or not it could have happened by chance. What that would mean, for example, interpreting that odds ratio, that's actually quite hard to interpret in real terms for people, say, working in dental practice, that for every 20 to 25 people who were receiving the intervention, an extra person was recorded as attending an NHS planned care appointment in the BSA dataset within 12 months, even given the situation about the difficulties in accessing care in that area at the time. Next slide, please. This is a couple of the secondary outcomes based again on planned care appointments because it gives you a bit of another picture about what's going on here. You can see here on the questionnaire basis, looking at whether or not people reported that they'd been for a planned care appointment, that the odds of them saying that they'd had a planned care appointment went up over time. And so that actually meant that by 18 months, for every 20 to 25 people, 1 to 2 extra people reported a routine attendance. So it was getting nearer to being statistically significant over time. And we see the same thing happening within 18 months, that the effect got stronger over time. But we still see within that 18 months that it crosses 1, the confidence interval. Next slide, please. So I'm going to talk you through OHIP 14 for people that are not familiar with OHIP 14. It's used internationally as a set of 14 questions that basically, taken together in what would be called a summary score, is an indication that people have poor oral health that's really impacting them. For example, in terms of pain or not being able to eat, feeling self-conscious, etc., feeling embarrassed. And this is all put into a score. They have a score for each question and they're all added up. So if low scores for OHIP 14 indicates that things are pretty good for that individual person and the impacts are low. Next slide, please. So this is primary outcome 2 at 12 months, self-reported OHIP 14. You want to see if the oral health impact has lessened, it means that the scores are lower. You can see here that, yes, indeed, the return intervention mean score is lower at 12 months than the control group, and the change gets more negative as well from baseline. But you'll also see we need to also think about whether or not this could have happened by random allocation, random sampling. And this shows that actually also the confidence interval includes naught, so it means that it also could have happened by chance. Next slide, please. What was much clearer in the data set is the secondary outcome about the attempts to make an appointment within 6, 12 and 18 months. It was very highly statistically significant, so this was without doubt beyond chance, that many more from the return intervention group at 6, 12 and 18 months made attempts to get an appointment. And it's very interesting to see that the odds ratio shows that the odds are 3 times higher at 18 months for the return group compared to standard care. And again, the intervention, which was delivered at baseline in just over 15 minutes, the impact of that got greater over time for the intervention group. Next slide, please. And for those not familiar with odds ratio, it roughly means that 18 months later, people receiving the return intervention had between 2 and 6 times higher odds. If we translate that into numbers, we see in the usual care group, actually quite a number of people had tried to make an appointment, about 90 people. But for the return intervention group, that would be about 97 out of 100 people. Next slide, please. Secondary outcome of OHIP at 6 and 18 months. You can actually see there's a repeated pattern here that we see again and again. At 6 months, you can see again there was a statistically significant reduction in OHIP 14 between the return and the usual care group. And this actually, for some reason, and I don't understand it, lessened over time. So that you can see that although we've still got a pattern that where it's lower for the return group, the difference reduced over time for OHIP 14. Next slide, please. Of interest to people will be the whether or not people reported that they'd had an antibiotic prescription for dental problems by a GP, A&E or walk-in centre within 18 months. And we see, again, we've got to think about whether or not this could have happened by chance, but we see the reduced odds ratio. And what that means is that the people that received the intervention had a lower odds of receiving an antibiotic prescription by a GP, A&E or walk-in centre within 18 months. Next slide, please. Here is just an indication about what happened in terms of the odds ratio for dental treatment received from the BSA data. We see here again, it's the pattern that we might expect from those other results, that the intervention group had a slightly lower odds of receiving urgent care and a slightly higher odds for receiving other types of care, although we see that it also could have happened by chance. Next slide, please. I have an interesting finding about dental anxiety here. This is the secondary outcome about the modified dental anxiety score here that you'll see is again a very established score about dental anxiety, where individuals answer a series of questions and score how anxious they feel about different types of treatment, and this is all totted up into an MDAS score. What you see is that the return group, their dental anxiety tends to decrease over time, and the difference between at 18 months of the return and the control group in terms of dental anxiety is statistically significant, whereas for the usual care group, their anxiety tended to increase over time. Next slide, please. So in summary, those are the headlines, and I've said we've got 14 secondary outcomes, and I've skated through these results very quickly because of time. But in summary, what you see is that you see across the range of outcomes, we found a clear finding that return significantly increased attempts to make routine appointments in this cohort of people, even given the difficulties of getting an appointment in this situation that was coming out of COVID. But we can say, using the GRADE methodology, that based on this randomised control trial, we're moderately certain that return produces small, consistently favourable effects on routine visits, oral health impact, and dental anxiety. And what is striking in terms of this longitudinal follow-up is that you get even though the intervention was delivered as a one-off, the intervention effect lasted for 18 months and got stronger over time. Thank you.
Okay, so we've planned to pause here for a couple of questions. And I think we've got time to answer those if you wanted to do that now, Rebecca. There's a couple in the Q&A and in the chat as well.
Right.
So we've got one from Christina that says, how did you account for the risk of rating of the patient for returning to a routine appointment when selecting 12 months and 18 months as a primary outcome?
It's interesting that, isn't it? That I'm not quite sure what Christina means about the risk rating, but we didn't know what we didn't know right at the start of this trial. And so I don't really know why we set 12 months for the primary outcome. Other than that, in real terms, if you want to make an impact on dental services, you'd want to see what happened within a year in terms of the delivery and the impact of your intervention, although we were interested to see what happens in the effect over time. What we didn't know is about the impact of the COVID pandemic would have happened in terms of the intervention and the delivery of that over time and the availability of it. And so I think part of the reason why the intervention effect tended to increase over time is the service availability actually got slightly better over time, depending on what stage that the patient themselves was recruited. So hopefully that answers it. I'm not quite sure that it does, but let's see. The next question is, I was thinking that participants in the intervention group may be more likely than those in the control group to provide socially desirable response. I suppose that's about randomisation, isn't it? I mean, what we did in terms of the the usual care group is that we did actually give them a video thanking them for their participation in the trial, and they also all received the follow-up phone calls, etc. They may have provided more socially desirable responses, and that's certainly something for us to think about. But I think given our breadth depth of secondary outcomes, they all indicate things in the same direction, and that was partly of the power of that other primary outcome, because we could validate that in terms of the centrally held BSA data that says the same thing. Yeah. So somebody else has asked about measuring trust in the dentist. No, the answer to that is that we didn't do that. Partly because we were mindful of the intervention being delivered to people that had relatively low education, and we wanted to minimise the amount of questions that they had to answer and the burden on the participants basically in the trial. And so there would have been a lot of things that we could have gathered during the trial, and we didn't do that. Although in the qualitative work that we did right at the start of the trial, that led into those 6 barriers, we did do a booklet specifically on I don't trust the dentist, because of all the qualitative work and the work with the community that went into that. So we've got quite a lot of qualitative work that sits behind that. There's actually a real issue about people having bad experiences and not trusting the dentist, and we spoke directly to that. We do have data on how many people identified with particular barriers, so we would know the number of people who identified with that barrier specifically. And then we've got somebody else saying, could they contribute to the project? Yes, it would be lovely. As Victoria said at the start, do please just email us and get in touch, because it would be lovely to hear from you and to discuss what you think about it and how you might contribute. Based on the feedback from the participating practices, thank you, Tom, how feasible do you think it would be for a more widespread policy measure? And I'm going to hand that over to Victoria, actually, because Victoria led the training of the dental nurses and the implementation into dental practices. And I think it would be good to hear what you think about that, Victoria.
Yeah, I think it was challenging in some practices and with some nurses, but bear in mind, when we were implementing this in practice, it came at the same time as having to also implement a clinical trial and everything that goes along with that at the same time. So that involved training nurses how to randomise, how to consent in terms of research. So there was quite a lot of training that had to happen outside of the intervention itself. From my experience and how involved I was with the practices, the intervention itself was the thing that the dental nurses found easiest and most enjoyable. But there are definitely barriers to it being implemented in practice, such as dedicated time, having the time for the training. And one of the main barriers for the dental nurses that we worked with was confidence. And this was actually part of my PhD work. So one of the things that we found was it will be most suited to dental nurses that probably already have patient-facing roles, or that have had more experience with patients in like a face-to-face capacity. So I do think it's something the dental nurses definitely enjoyed. They were good at it, actually, really good at it. But it needed to be a particular type of nurse, and it really needed a whole team effort to make it work. So dentists needed to be aware that what was going on, the extra time that needed to be allocated for it. I hope that answers your question.
Then I'll just pick up another question here from Anoop as well. That said, and I think this is, as a public health academic, Anoop, I can really appreciate where you're coming from, and it's something that we all struggle with. Is it worth doing an RCT that's focused on an individual intervention that can be over, because they're facing such overwhelming other sort of like factors, such as cost of care and the difficulty in getting into care, particularly for new patients? And I think that's a really good point, and it's the point that I was trying to sort of like make early on, really, is that this is one approach, that we need to get the system right, that's for sure, but there is work to do for these individual users as well. And we found, particularly if we have time to go through the qualitative work, how many people really appreciated the intervention to support them into using the services that are there for them and to follow through with routine care, which is to their benefit as well. But there's a paper written, an excellent paper written by Dan McNeil in America, and he talks about this very much in terms of the behavioural interventions and where we should be with the science. And he says for sure we should attend to the differences in health inequalities. But the challenge is now we need to be able to do something to support those people that are finding it really difficult for now. And so this is something that's used alongside system intervention, health services redesign, but we also need to support people as individuals too. So hopefully that addresses that point.
I think we probably need to move on to the rest of the...
Yes.
Yeah.
Okay.
So next up, we've got Dan. So I'm going to hand over to Dr. Dan Howard, a health economist from Leeds University, who will talk you through the health economic results.
Hello, yeah. Can you hear me all right? Yeah.
Yeah.
There were a couple of issues before. Great. All right. So obviously what we've heard so far is results on the clinical effectiveness, so at an individual level. Are kind of related, but not kind of guaranteed to have a similar outcome is a question of cost effectiveness. So while we might have established to a reasonable degree that it's clinically effective, we've seen the impact on primary outcomes, secondary outcomes, we also want to see this. So at a population level, does the intervention improve overall health? So something that might seem paradoxical in particular to people whose primary focus is understandably the patient in the room in front of them, something that's shown to be clinically effective, might actually reduce overall population health. This is because of if it costs an additional amount, and that additional amount of costs means that ultimately we reduce provision of more cost-effective treatments to remain within a health system budget, we do need to recognise that there is a trade-off here. So it might be the case that an expensive intervention, which improves the health of the people who receive it, might actually reduce health at a population level because of that increase in costs that reduces health elsewhere in the system. So what we do for this is to use the kind of standard measures and approaches that we have within health economics. So again, people might be familiar with the idea of QALYs, so where we have a health outcome measured in terms of years of both length of life and quality of life experienced over the relevant time period. I'll say a little bit more about those on the next slide. What we do is ultimately, what we want to have an estimate of is how much it costs to get an additional one of these QALYs, these units of health. And secondly, to have a look at, given that might be our best, even though that might be our best estimate, there is going to remain uncertainty around this. What is the probability that it is actually cost effective in standard measures? Roughly speaking, we can see this as improving population health, the probability of improving population health. Could I have the next slide, please? Sorry, I hate doing that. Sound like Chris Whitty. So we've got yes, as I said, we'll think here about the what a QALY is. As I sort of roughly said, it's perfect quality health for 1 year. We'll collect this using a questionnaire called the EQ5D5L. So 5D stands for 5 dimensions of health. So we ask people about their mobility, their ability to care for themselves, their ability to carry out usual activities, any pain and discomfort they might be experiencing, any anxiety and depression they might be experiencing. And they are on 5 levels, hence 5L. So that goes from no problems, slight problems, moderate problems, severe problems, extreme problems. So we ask this questionnaire. This is supposed to be a kind of generic account of health, which is comparable across different types of health. So dental or kind of interventions targeting primarily mental health or palliative care. All of these things are supposed to be equivalently captured within this generic measure of health. On the other side of this, we'll have costs. And as I say, costs here are supposed to be a proxy for health that we lose. So costs here, while we might measure them in financial terms, in monetary terms, and we do here by getting questionnaire responses from patients on primary care usage, so usual primary care GPs, A&E use, medication usage. We also get administrative records of other types of primary care and other types of hospital use, dental hospital use, sorry. We cost those using kind of nationally recognised, publicly available records. So the sort of the most obvious one, I suppose, here is a UDA, unit of dental activity, is the median cost of that within the UK is £32.44. That's primarily used for dental reimbursement. This is one of like the key factors in this, but all of these things we do actually try and capture the costs of. The additional thing that we need to cost is the intervention, and by looking at the cost of the packs that were provided, the nurses' time, this came to approximately £17 per person. So the idea here is these costs are in a monetary terms, but they're supposed to represent foregone health. Have the next slide, please. So again, we've got two sets of results here. One is complete cases, where all we do is, if someone failed to respond to a particular bit of the questionnaire, we exclude them. We're going to see on the next slide what we do to try to include on the best possible basis those. What we look at here is incremental net health benefit. That's our primary outcome measure. And what this is supposed to represent is, once we take into account any health that we lose by increasing costs elsewhere in the system, do we still have an increase in population health? And what we find here is the increase in QALY, so the increase in health for the people receiving the intervention, is about 0.020 QALYs. This is about 7 days of extra health over 7 days of extra perfect quality health over a year. The incremental QALYs is that, costs is that it goes up by about £24. It's very cheap intervention by most standards. So what we find here is this has a 99.7% probability of being cost effective at standard measures. Now, that's possibly even higher than it sounds in relative terms. What all we're looking for here is that the probability of cost effectiveness is greater than 50%. What we have here is actually 99.7%. So it's an extremely, it's an intervention that is increasing population health, individual health for those experiencing the intervention, and the probability of this being cost effective at a threshold of, you may have seen this in the news because there's been in the last couple of days a trade negotiation on this where this threshold has been increased, but the current ones that we use are £20,000 to £30,000. And at those thresholds, the probability of cost effectiveness is 99.7%. So extremely highly likely to be cost effective. Could I have the next slide, please? Oh, sorry, I should say these are qualitatively similar at 18 months. Could I have the next slide, please? So the multiple imputation results, again, there's not a great deal extra to see here, but just to sort of reassure people, if you are concerned about this, it's not that we're cherry picking results. These are qualitatively similar. We've got a slightly lower incremental cost, so that means the intervention is associated with a very small, a slightly smaller increase in cost compared to the previous slide. We have slightly lower incremental QALYs, which suggests actually maybe the increase in health is slightly lower than was said before, but still 5 days of perfect quality health is genuinely a big number in the context of the trials that we see here. Again, we've got an increase in population health with very high probability, with very high confidence. Just to reiterate, 90.5%, don't worry about 95% confidence intervals. That's not the way in which we sort of make decisions. Ultimately, our view is that it's no better to approve something that you should reject rather than reject something you should approve. If you like, it's kind of like a civil burden of proof in this situation, rather than kind of more like a criminal burden of proof in the sense of the standard clinical outcome, where we're stacking the decks against sort of getting a false positive. Here, because we have to make a decision, we don't think it's better to approve or reject disproportionately. And again, the results are qualitatively similar at 18 months. So the summary of both of those is that, one, it improves population health. Two, we're very confident in that. Go to the next slide, please. We haven't missed the out-of-pocket one there, have we? No, did you skip forward two? That's fine, sorry. So what we can also look at are the subgroups within this. So as Rebecca pointed out before, what we can look at here is that this intervention was a large proportion of the take-up here was in low-income groups or high deprivation groups. So one is the most deprived here. If we cut this analysis down by subgroup, we have the highest confidence. Again, this is partly an artifact of the disproportionate recruitment in these most deprived groups. But one thing we can be pretty well reassured about here is that within the groups who we might be most concerned about, the probability of cost effectiveness here is the highest. And once we get to the sort of least deprived group, actually, we don't think this is, one, we think this is not cost effective, and two, not just that, but it's very unlikely to be cost effective as well. Our best estimate is not cost effective, and two, pretty high confidence, very high confidence, in fact, that it is not cost effective. So we're pretty, in these most deprived groups, these low income quintiles or low high deprivation quintiles, we're most confident. that it is cost effective, and we've got good evidence that it is. I would say don't read too much into the variation at the top end, because we've got substantial uncertainty rising out of only a few people being in these groups. Could I have the next slide, please? So the final thing we're going to look at is out-of-pocket costs. So what we have here is a kind of comparison, first of all, just in sort of descriptive statistics, i.e. in a kind of, if we look at these raw numbers, do we seem to have higher costs in one arm or another? What we really want to do, and what we ultimately do, is try and adjust these in the same way as we did for the clinical outcomes for different sort of imbalances at baseline. So the things Rebecca talked about there, about like indices of deprivation, maybe about gender, about things that that might be relevant in explaining outcomes. Once we adjust for all of those, what we find is, what I would say is some tentative evidence that this might reduce pay loss. So we do have a best estimate of £22.50 lower pay loss in the intervention arm. Now, if you take that as a question on its own, at significant, at conventional significant levels, at the usual in which we carry out the statistical analysis in the way that Rebecca discussed earlier, what we find here is that this is significant at those usual ways of doing it. One danger, however, is when we compare lots and lots of groups, we can get false positives by checking for lots of things. So we do need to see this as quite tentative, but there is some suggestion there that this may lead to lower pay loss as a result of the intervention. Could I have the last slide, please? So yeah, so just in summary, I think, these are pretty robust results, irrespective of whether we take 12 months or 18 months, no matter whether we adjust for missingness or not. We're pretty confident this would improve population health, that this is a highly robust result. As I say, between 5 to 7 additional days of perfect quality health over the years, probably the most intuitive way to word it. And it's pretty similar to that at the population level because the costs are very low. I think there is a good case for looking at longer term decision modelling to think about whether this does increase over time or whether there's a difference over time. We've only really analysed 12 to 18 months here. And as I say, we have that tentative suggestion that pay loss may be reduced. So there may be additional benefits to the patient over and above what we're seeing in terms of the intervention itself, at a population level rather. Okay.
Thanks very much, Dan. So finally, we've got Professor Harris, who's going to speak about the qualitative findings that went alongside the trial.
Thank you, Victoria. And if anybody has got any further questions about the health economics, perhaps if you can, I'm conscious of the time, but if you want to put the Q&As perhaps in the chat, or not in the chat, but in the Q&A bit, then Dan will be able to sort of like correspond with you while I'm talking, perhaps. So the qualitative findings, we actually had in-depth, as well as the questionnaires, we followed up people for in-depth interviews, and we sampled 55 individuals, and we followed them up for interviews at 6 months, 12 months and 18 months for a longer discussion with them about what the intervention felt like, what they did with it, both in the intervention group and also in the control group, so we could understand what was happening to that control group too. So that's what I'm going to talk you through next. Next slide, please. What we found is that for different people, different elements of the intervention were particularly powerful. So we couldn't say that it was all down to the intervention pack itself. It wasn't all down to the conversation. It wasn't all down to the video or the plan. What we probably didn't see, and I don't think we've mentioned up to now, that we did send them a follow-up text after that baseline visit just to reinforce and deliver the plan that they'd made with an encouraging message. But when we spoke to the people in the qualitative work, quite a few people couldn't recall the text, and nobody said really that it was particularly helpful for them. So we'd sort of think about that as not really a sort of part of an intervention package going forward. But what we found that for some people, there were different elements that had a synergy together. And for some individuals, there was a standout, powerful moment with one or two components of it, for example, the nurse conversation or the video. And it was hard to predict by different people and different type of people. You'll see here just for one individual person who was just a relatively young man who was unemployed, all of these intervention components, such as the conversation that really made him stop and think about whether or not actually I can do this. And then he had the help with the booklet to say that, yeah, to give him the script, if we said in the chat, that it provides some script to making appointments, to dealing with the receptionist, etc., to getting over that hump, as we've seen in the video earlier. And then the material about committing and thinking through a plan to make a planned care appointment was also useful. Next slide, please. Partly the powerful moment was the fact that when they attended urgent care, even though they didn't anticipate this coming, and even though those people were in pain at the time, it provided a moment, that conversation, for them to stop and think and to reflect what was happening to them in their lives, that they'd actually turned up at urgent care and had been in this pickle, basically. And for some of them, it was a moment to be encouraged to stop and think about what's happening here to me. I need to handle this a bit better next time. And that was repeatedly something that we saw in the qualitative work as being quite powerful. Next slide, please. Now, we often talk about self-responsibility in terms of dental services because prevention is basically a self-care activity quite widely. And there's been a lot of behaviour change discussion on about like trying to get patients to take responsibility for themselves. Now, this wasn't particularly something that was written into the material itself. The message of the behaviour change messages in the material itself are not directly saying at all, I've got to take control of this. But this is what they took away. They took away and you can see quotes from various people here, that it gave them a push and a commitment to say, no, I've got to sort this out. And that was the messages that they were taking away, that they've got to take some personal responsibility for this in their lives. Next slide, please. Something that came through particularly from quite a few participants was that through engaging with the material, quite often with the videos, that we took a lot of care to reflect the local social identity, that people were quite surprised. For some, it was genuinely new that there were other people that felt as anxious about going to the dentist as they did, and that we're encountering the same thoughts, for example, about not trusting dentists, etc., and finding it difficult, or not thinking to go whether or not they were in pain. So that was a striking finding with the qualitative work. The social identity resonated with people, and they felt less alone, and that helped them feel more able to tackle this because they could see other people could do it too. Next slide, please. Now, Victoria mentioned the Next Appointment Toolkit, which is a small booklet in the intervention pack. What we did, mindful of the wanting to design this with a very low reading age, we didn't want one booklet, so that's why all of the booklets are just 2 or 3 pages. But we've got the Next Appointment Toolkit that has things like breathing exercises to prepare as part of the material to prepare people for their next appointment. And you can see here the feedback that we got from people who would use the scripts, who'd interacted with the hard copy material. But this is just a set of quotes from an individual, older lady actually, who was saying that the breathing exercises was something that was put in there to help people relax, to prepare them to go to their appointment. But they were training themselves at home in order to prepare for that, and they were sharing it with family members too. Next slide, please. The intervention was given as a pack for these people to take away with them, and we designed it in such a way that people could write in it, so that people did firstly keep the pack, even though they had quite a low educational level, but they also interacted with it and used it, quite a few people as well. You can see the quote here from this guy who's an engineer. Initially, he wasn't sort of like that keen on it, but when he got the pack home, then he started to reflect and look through it and started to think about actually putting it into practice, which may have been partly due to the effect that this intervention lasted so long over time. We did this because we were mindful that being opportunistic and turning up for urgent care, people's minds are obviously all over the place and they may retain a bit, but having the intervention pack to take away with them would sort of like reinforce the effect. And people seem to appreciate that. Next slide, please. So, as I said, the physicality of the booklets was often quite important. It was nicely produced, to be sure, and not something that you would readily put in the bin unless you really didn't want to pay any attention to this at all. But what we found is that people actually use this material for quite some time. There's a quote here from a long distance lorry driver, for example, who'd kept it in his cab for like 12 months or so that it was like a continual reminder, a physical reminder in terms of I need to actually deal with this issue in my life. Next slide, please. And then the other thing to comment on and reflect on, and I think this is encouraging for us, mainly working in the dental field, is that a dental intervention had some rippling effects throughout people's lives in general. Now, as I've outlined earlier, these people, as a social demographic group, were actually relatively disadvantaged. And this individual here was a guy who'd unfortunately suffered a work accident and was unemployed with a disability. But as a result of the intervention itself, because it worked for him in terms of his dental visiting and getting him to the dentist, he also used the same techniques to start tackling other issues in his life. He says, I've also made action plans to tackle my weight, stop smoking, and everything else because of the booklet you gave me, believe it or not. It was about writing it down. Since last November, I've written everything down. It sounds stupid, but it was because of the booklets, or I wouldn't have done it. He said that this guy had actually lost a limb, but he wrote down when he was going to exercise, go to the physio, etc., getting back into a routine. He's joined a no smoking course. He started getting his health checks done, and he actually even joined a gym. Next slide, please. This is another individual person where it also from IMD1 had been 5 to 6 years since she'd actually visited a dentist. It actually made a huge impact on her life. And I think this is sort of like touching to those general issues of oral health as it impacts people's lives as a whole and their health services use in general, but also their daily living. Now, this was an individual who was in an unhappy relationship. And in that teachable moment of turning up, I think it was at the dental hospital for care, she suddenly realised that she'd been on a loop taking medication for the toothache. But there was something happening in her private life that meant that she wasn't paying attention to herself as a priority in the midst of other priorities in her life. So as she said here in that second column here, it was a turning point, that self-realization that I've talked about earlier. It was the beginning of a journey to think about her self-confidence, to believe in me as a person and to give me a higher level of importance. So she actually left a partner, she left her job, she relocated to a different area of the country. In the midst of all of that, it took her 2.5 months to find a dentist. But she said it was the best thing that she'd ever done because she actually managed to overcome her dental anxiety. She had a number of root canals and she's a very committed dental attender. Her whole life is more stable now because everything has come together. But this was a turning point as a teachable moment for her that turned round just her oral health, but it actually had these rippling effects throughout the rest of her life, which is very interesting to see in the wider qualitative work. Thank you. So we've come to the end of the presentation now, and so if there are any other questions or comments, we'd be very happy to take them.
There are a couple of sort of comments in the chat, Rebecca. I don't know if you want to have a look at them.
Sorry, where am I now?
You might just scroll up a little bit. I think Simon has said something a little bit further up, which you might be able to talk to about stabilisation.
Right. Is it possible to put Simon on and unmute him if Simon's still here?
Oh, I think he's gone.
Okay, that's fine. And there's a new message at the bottom. Oh, right. Thank you from Debs from Pittsburgh for the well-conducted study. I think people like Debs will realise what it takes to actually do a study like this, and it's difficult because, like, even though these people were from quite a relatively low educational group and quite disadvantaged, they also had to be enrolled in a clinical trial. And in terms of generalizability, that's another thing to bear in mind, that we were asking a lot of these individuals because they had to fill in the clinical trial paperwork, they had to be consented into a study, they had to understand and be shown things like the data protection regulations, information, and all that sort of thing. So there was a lot for the participants in the trial to cope with all at once. I think going back to Tom's point earlier about like this translation of a research like this into everyday clinical practice, this might look actually a little bit different in terms of the impact in everyday practice, because the type of participants who would then and even the effort from the dental team, as Victoria said earlier, they wouldn't have to go through the trial aspects of that. They would just have to get on and deliver the intervention, and that would reduce quite a lot of the burden on both participants and the dental team.
We've got a question from Yasmin in the Q&A. She said, apologies, I missed the start due to a delayed meeting. Do you have any comments about the face-to-face nature of the intervention, i.e. could be completed remotely / on the phone?
Ooh, now that's a really I think, and it's the same issue, isn't it, as to whether or not it could be an online intervention as well. So, and I think it's a next stage of research. I think the results of return indicate that it is possible for this group of users to change their behaviour and to their benefit. Whether or not the same thing works in a different form is a slightly different research question, but a development of it, and it probably needs to be tested and developed and piloted itself. I think people did really value even the discussion, even if it was brief by a face-to-face dental nurse in the team, to just talk about their fears in the moment when they were there. And that was quite powerful. Could it have also worked, say, before the appointment on the phone, for example? I don't know. It may have done, and anything might help these people, particularly supported by the material as well. But given the literacy of this type of population, I think we also have to bear in mind that I think they may well want a face-to-face as well. And particularly since we gave them a link to online materials like the videos, etc., at the time that they were recruited in the trial, and we looked to see if anybody had used the online link afterwards, and very, very, very few people did, even though they had the password to get into it. What they really valued was the materials. Now, whether or not we can make it more accessible with a phone call and in different ways is a further question. But I think that's something that we need to think about separately, and it needs to be evaluated as well. Because it may be just me, but I'm concerned about digital exclusion as well.
I think we've probably got time just for this last question in the chat, in the Q&A, sorry, which says, is the tool just for patients to fill out and keep for themselves? Is there any opportunity that the dentist DCP could read the patient's completed form, which I think probably sits with what you've just been saying there, Rebecca, a bit about future development?
Yes. Now, in the development of this intervention, we were aware of the work that was done by Professor Marchment in Sheffield and the CBT for children, and they had your dentist, you're in control, something like that in terms of their project, and they also had a letter to the dentist, for example, and some interaction with the dentist, and the dentist could complete things. And when we piloted it, that was just found to be redundant. It was felt that this was very much something that was making the inner thoughts of these individuals, and it helped them to put down on paper their thought process of what they were thinking and going through, with the encouragement of somebody who was helping them, making it detailed enough and supporting the process. So I think in psychological terms, there's something powerful about them making their own plans, and to be supported of that. But we don't know, basically, as to whether or not it would have had a similar effect if somebody was sat next to them writing and supporting them. And have you got any further thoughts on that, Victoria?
No, I agree. I think it was always designed to be very much a patient-facing kind of piece of work, wasn't it? And I also agree with your comments about the Dear Dentist letter, I think patients weren't keen on using that for whatever reason that might have been. And I think it would be like a further development piece of work to look at what that might be like, to have a bit more of a collaborative tool within it that could be used between patient and dental practitioner.
Yes. Yes.
So I think that's probably, we're bang on time actually, which is great.
Yes.
So I think we should wrap it up now.
Yes, and there's just one further thing to mention, that if you're somebody from a dental team that wants a CPD certificate or whatever, to sort of like get in touch and we can organise a CPD certificate for you. If you do want to discuss it further, just do drop us an email here and we'll pick up with you outside the webinar. But thank you so much for spending the time joining us today.
Thank you very much.
Thank you. Bye.